Good morning, everybody. So, today's topic is about Meniere's disease. Meniere's disease, as we all know, is a very common cause for giddiness or vertigo. So, by definition, it has got three components. One is fluctuating hearing loss, another is vertigo, and then next is tinnitus. Tinnitus is also known as ringing sensation in the ears. So, these three components will actually lead to Meniere's disease. Now, what is the age distribution and incidence? Age distribution, it is usually seen in age group between 35 to 60 years, and females are affected more than the males. It runs in families. It can be either unilateral or bilateral. Etiology, there can be anatomical abnormalities which we will discuss later. It can be genetic. It is usually autosomal dominant, or the other reasons for Meniere's disease can be immune complex deposition or serum IgE to herpes simplex virus type 1, 2, Epstein-Barr virus and CMV, cytomegalovirus, or vascular associated with migraines or metabolic potassium intoxication. So, endolymphatic sac, this is the just for to revise where is endolymphatic sac situated, we have put up this diagram. So, it has got a saccular duct, uticular duct, sinus of endolymphatic duct, and the isthmus of endolymphatic duct. And we can see here the endolymphatic sac, it has got two portions. One is intraosseous part and another is extraosseous part. So, intraosseous and extraosseous components of the endolymphatic sac are very important in future surgeries. Now, what is the pathophysiology? The pathophysiology is there is dilatation of the endolymphatic sac. Okay, so as we can see, this is the normal membranous labyrinth. This is the normal membranous labyrinth. But here there is dilatation of the endolymphatic sac, and that is the reason for Meniere's disease, or it is also known as hydrops. So now what happens? There is distension of the endolymphatic sac, and it leads to the atrophy of the Reisner's membrane. The endolymph is released and it is getting mixed with the perilymph. So when endolymph is getting mixed with the perilymph, then there is a unequal distribution of the ions, and sensory and the neural structures, they are exposed to potassium rich endolymph, so that will lead to sudden hearing loss and vertigo. Now, when the symptoms subside, so there is always fluctuation. When the distension reduces, the patient feels normal. Again, when there is distension of sac, again the same cycle will follow, and the patient will have giddiness, vertigo, and sensory neural hearing loss. So it comes in bursts, and every time the patient will not be having the same symptoms. So it comes and goes. There are certain episodes of Meniere's disease when it becomes very severe and you will have to treat actively. What are the clinical features? As I told, vertigo, deafness, and tinnitus. But what is the characteristic of vertigo? It is episodic. That is, it comes in bursts and goes, and it is sudden. You can never know when the endolymphatic sac will be distended and when it won't. It can be rotatory. Then it can last for 24 minutes to 24 hours. Then nausea, vomiting, and diarrhea. It can be associated with all these features. Deafness is fluctuant. It is not always same. It is progressive, low frequency hearing loss, sensory neural hearing loss, and there is diplacosis. That means there is distortion of sound. Okay. Tinnitus and oral fullness. Tullio's phenomena is one of the characteristic feature of Meniere's disease. What is it? There is a subjective imbalance and nystagmus which is observed in response to loud sound, low frequency noise exposure. One of the reasons why it happens is because of the distension of the endolymphatic sac, there can be abnormal undue pressure over the footplate of the stapes. When there is undue pressure, that can lead to subjective imbalance. The inner ear and the labyrinth get stimulated, and there can be subjective imbalance and nystagmus due to loud sound. Otoscopic examination looks perfectly normal. There is no abnormality in the tympanic membrane, but you can observe during the episodic bursts, you can observe nystagmus, which is horizontal and rotatory. And tuning fork test will show sensory neural hearing loss. When we do a pure tone audiogram, you can see that only the low frequencies are affected, and there is significant sensory neural hearing loss. Speech audiometry, the discrimination is slightly poor, but the main pathognomonic feature of cochlear injury is recruitment. Recruitment is nothing but abnormal growth of the loudness with short increment in the sounds. Whenever there is a short increment in the sound, or whenever there is a small increase in the intensity of the sound, patient can hear patient can hear the same sound, but it is abnormally loud. It is very loud. He can, when compared to normal individuals, he will hear it very loudly. SISI is also short increment sensitivity index, that is, when the sounds are produced, even a small increase in the decibel level, the sensitivity is increased. The sensitivity of that ear is increased. So that is known as, that is a small test. That is also a pathognomonic feature of cochlear hearing loss. So SISI is more than 70%. One more is electrocardiogram. In electrocardiogram, as we see, the action potential, thus ratio of the summating potential and the action potential is always 30%, that is 0.3. But in Meniere's disease, what happens is the ratio of summating potential to the action potential is less than 30%. As we can see in the graph, it is less than 30%. So this is also pathognomonic feature of Meniere's disease. Glycerol test. What is glycerol test? When we administer glycerol, we actually administer glycerol at the rate of 1.5 ml per kg per body weight. You give it half an hour to 1 hour intervals, and when you record the audiogram, there is a improvement, 5 decibel improvement in 3 consecutive frequencies. So you keep giving glycerol, and then what happens is the distension of the endolymphatic sac reduces. So as a result of this, there is an improvement in audiogram, that is at least 5 dB improvement in 3 consecutive frequencies. So what is the treatment? Dietary modification and diuretics. What dietary modifications? Low salt diet, okay, and certain things to reduce weight, high fiber and low salt diet, and diuretics. This is all to reduce the distension of the endolymphatic sac. Vasodilators, again same. Symptomatic treatment, anti-vertiginous medications like cinnarizine. Cinnarizine can be given, Stemetil can be given, which is nothing but prochlorperazine. Antiemetics, when he has nausea, vomiting, you can give sedatives like Angsit, antidepressant, psychiatric treatment, and local overpressure therapy. Meniere's therapy is actually a device which can be presented to the ear, and there are some certain studies which show that continuous sound which is presented to the ear can actually reduce the hearing loss and vertigo, because it provides continuous pressure, and the distension of the endolymphatic sac reduces. So as I told you, low sodium diet, restriction in caffeine, nicotine, alcohol, whichever is triggering factor for Meniere's disease, that has to be avoided. Now, what is the surgical treatment? What are the options? Intratympanic injection, endolymphatic sac surgery, nerve section, and labyrinthectomy. Among all these, now we will see how is intratympanic injection given. So first we will puncture the tympanic membrane, and the needle is just above the round window. As you see, the needle is just above the round window, and 0.5 ml of hyaluronidase and 1 ml of dexamethasone is mixed together, and it is injected in the middle ear. Patient is instructed to lie down for 3 hours, and the entire process is repeated for 3 consecutive days. So dexamethasone is a better choice for intratympanic injection. You can also give transtympanic gentamicin perfusion, and that has seen to control the vertigo by 80 to 85%. Then transmastoid endolymphatic sac procedure, transmastoid labyrinthectomy. Okay, so these are all the surgical procedures which can be